Hello, my name is Marisa Mercer. I'm an F&P student at the University of Texas, El Paso. Today I'm going to be doing an assessment of the thorax and the lungs, and then also cardiovascular system in a separate video. My volunteer here is Chris, and he has come to see me today. And with the respiratory system, really the assessment begins the moment the patient walks into the room. I'm noticing how he's breathing, rate, rhythm, depth. Does he appear to be in any respiratory distress? I'm also noticing his positioning. Does it seem like he's struggling to breathe? Tripod positioning. Also noticing his skin color, looking for any pallor, any cyanosis. So it looks like he's breathing perfectly normal, normal rate, rhythm, and depth. His skin looks good. I don't notice any pallor. I'm also looking at his fingernails, looking for any clubbing or also cyanosis there. Lips look good. So first I'm going to visually inspect his chest. So I'll have to have you take your shirt off for that. Is that okay?
Yes.
Okay. You can go ahead and take your shirt off. So visually I'm looking for any kind of deformities here. Looking for any barrel chest, flow chest, pigeon chest. It looks like he has a nice normal symmetrical chest. I don't notice any unilateral lag in his respiratory movements. Do you have any tender or sensitive painful areas on your chest?
No.
Okay. Any history of trauma, broken ribs?
No.
Okay. All right. So I'm noticing here that he has a nice normal chest, good muscle bulk. He's breathing normal. What I'm going to do now is I'm going to check for chest expansion, and what I want to see is I want to see nice symmetrical chest expansion whenever he takes a nice deep breath in. So I'm going to come over here and I'm going to pull forward and have my thumbs touch here. Now I need you to take a deep breath for me. And then I'm noticing as my thumbs pull apart as his chest expands, if it's symmetrical or if there's a unilateral lag, which could indicate maybe paralysis of the hemidiaphragm or some other underlying lung pathology. I'm going to do the same thing on the back, so I'm going to turn around. Right here, okay. All right, I'm going to pull together and get my thumbs together, and I'll take a deep breath in for me. Again, nice symmetrical movement of my thumbs apart. So next I'm going to check for tactile fremitus, which we'll do front and we'll do back. Tactile fremitus, I'm feeling for the vibration in the chest as it crosses through the chest wall. What I don't want to see is an absence of fremitus or a decrease or increase or asymmetry from one side to the other, because that could indicate maybe fluid buildup or air, such as like a pneumothorax, pneumonia, cystic fibrosis. So when I check for tactile fremitus, I'm going to use a bony part of my hand. I could either use this side or I could use the palm. So I'm going to do both. And when my hand touches your chest, I want you to say 99.
99.
I'm having him say 99 because it's a low pitched sound and I can feel the expected amount of fremitus here. I'm going to go down here.
99.
Okay. And then here.
99.
Okay. And do the back side as well.
99. 99. 99. 99.
Perfect. So tactile fremitus for him is expected. There is no increase, decrease, or absence there. Next, I'm going to percuss the chest, and this is just another way to help give me a better picture of what's going on with his lungs. I'm combining all of these assessments to kind of get an idea of what might be happening. So for example, if he had pneumonia, or if I suspected pneumonia, as I do this, I would expect some dullness or maybe decreased fremitus. So we're going to do percussion here, and I'm going to have you relax your arms. And I'm going to go in a sequence from top to bottom and work my way down, and then I will also do the back side. So I'm getting the expected resonance in all areas in the front here. I'm going to do the back side as well. Now, as I percuss, what I might notice over on this side, as I get closer to the liver, is I might feel or hear that dullness, which is expected here, or maybe on this side, over the heart and over the spleen area. On the back side, I should have all of the expected resonance, unless he had maybe some consolidation in his lungs or some underlying pathology, or if he had a pneumothorax, I might hear more of a hyperresonance as I percussed. So next, I'm going to listen to his lungs. Here, I'm trying to listen for any kind of adventitious breath sounds, such as wheezes, rhonchi, coarse or fine crackles. And here, I would expect to hear tracheal sounds here, which would be higher pitched. Also in the supraclavicular fossa, I would expect to hear higher pitched tracheal sounds. And then as I come down to the manubrium, I would expect to hear bronchial sounds. And then over the second intercostal space, both on the right and the left, I would hear bronchovesicular, and then I would hear vesicular breath sounds throughout the main areas of the lungs. So I'm going to have a listen here, have you take deep breaths, and again, I'm going to go from top to bottom and go in a nice orderly fashion so I can appreciate all areas of the lung. Okay, I'm going to move on to the back. His lung sounds clear in the front. Can you lift your arm a little for me? Gonna get up into his axillary area so I can try to hear the apex of the lung. Breath. Wonderful. So all lung sounds are clear. I could also be assessed for transmitted voice sounds as I listen and have him say 99. But I'm not going to go through all of those. But if I wanted to get a little bit more of an idea of what was going on, I can have him do that as well. So that concludes the lung and the thorax. He is a nice, healthy patient. Thank you so much for helping me out and participating, Chris.
You're welcome.
All right, cardiovascular will be next.